Here we see the oncology private hospital, the Fernandez Hospital, the Cetrangolo Hospital. The Argentine Republic is situated in South America with a population of 30 million inhabitants and a surface that is over 2,800,000 square kilometers. Japan has a surface of 369,000 square kilometers with a population that is over 120 million inhabitants. Some fundamental contributions of the Argentine medicine to the world surgery are the citratus blood transfusion in 1914 by Luis Agote, surgical techniques and instruments by Enrique Finocchieto, we see his picture, and more recently Dr. Favaloro, who made contributions to cardiac surgery. The private hospital where he works is seen. There are 3 Argentine doctors who were awarded the Nobel Prize in Biological and Medical Science: Husay in 1947, Leloir in 1970, and Milstein in 1984. The first mediastinal lymph node dissection, from now on we called MLND, in lung cancer, is attributed to Brock and Allison in 1949, and they call it by its name radical pneumonectomy. We feel that Watson, Allison, Churchill, Sweet, Sutter, Gordon Scannell, Cahan deserved a similar place for their dedication to the subject. It will be only fair that history will record that Tsugo Naruke, after a period of pessimism concerning these surgeries, reassumed the dissection technique with some changes as compared to those described in the 50s. He released in a practical way a lymph node mapping and generated the idea, based on a wide experience, that MLND is not only a surgical staging for prognosis, but that it has, furthermore, a therapeutical impliance. Some years ago, we stated in a general way that out of 100 patients with lung cancer, 50 were inoperable, 60% of the other 50 were resected. Out of these 30 patients, 30% survived after 5 years. This meant a 9% survival in the first 100 cases. Today, out of 100 patients with lung cancer, 67 are inoperable. Out of the 33 that undergo surgery, 31 patients are resected. Survival after 5 years reaches 30%, that is 9% of the total. This mathematical fancy shows survival figures similar to those registered 20 years ago. Nevertheless, things have changed for the better. The technological development of pre-surgical studies has attained a higher precision in diagnosis, a better selection in surgical indication, delimiting with exactness the staging of the disease. The general use of auto-suture instruments, more aggressive intraoperative techniques, intrapericardial ligation of the vessels, tracheal and tracheobronchoplasty, the wide opening of the mediastinal pleura with lymph node dissection, and the developments in post-operative intensive cares, all this has allowed us the resection of more advanced and thus better final results. 3 points can be considered as responsible for changes in the therapeutical point of view in my country. First, my trip in September-October 1984 to visit the National Cancer Center Hospital, where I learned the MLND technique for lung cancer. We applied what we learned, and we talked about the methodology used after being applied to the first 10 patients in the year 1985 in the Argentine Academy of Surgery. Then we made successive publications with a greater number of cases, trying to have this proceeding prevail. The interest shown by doctors from the city of Rosario at the end of 1984 promoted what was called national meetings, mediastinal lymph node groups, and lung cancer staging. where we specifically discuss the role of MLND in lung cancer. The first one took place in 1985, the second in 1986, and the third in 1987. Last but not least, we must mention the trip made by Tsugo Naruke in the winter session of the year 1987, who delivered lectures in Buenos Aires and in Córdoba, reaching the climax needed, changing the ideas of the Argentine surgeons specialized in thorax. At these meetings, we decided first to adopt Naruke's lymph node mapping with the anatomic leading elements added by the American Thoracic Society. Second, the use of the new international staging, and third, to establish as compulsory the opening of the mediastinal pleura to appraise the M2, leaving 3 tactical possibilities to personal criteria: isolate groups 2, 4, and 7, loco-regional dissection, or complete MLND. Thus, the conclusion reached is that lymph node groups are to be studied most precisely, and whenever possible, they are to be dissected with a tumor during surgery. Since that moment, all groups rediscovered the mediastinal lymph nodes, and hence the value of staging cannot be denied, although the therapeutical impliance may be questioned. 18 renowned thoracic groups in Argentina adopted a similar criteria following the decisions of the above-mentioned national meetings. A few days ago, November 11 and 12, the national meetings gathered of the 18 groups 10 to produce by computerized system the first national cases statistics. Overall figures are shown. 612 patients, 536 males, 36 females, epidermoids 214, adenocarcinomas 295, others 103, resected graded 80%. The new international staging has solved, at least for the time being, 2 factors that previous staging did not. A. Factor T. T3 include diverse tumors with different prognosis, meaning the inclusion of T4 and the regrouping of tumors under these 2 categories solved this problem. B. Factor N. N2 included variable degrees of mediastinal nodes invasion with diverse therapeutic possibilities and different prognosis feasibilities solved by adding N3. Reviewing important statistical cases has enabled to know that lymph node involvement is the isolated sign of most serious prognosis in the development of the disease. Identification during pre-surgical period of TNM factors compel us to know and evaluate in a precise way the CT scan with predetermined transversal section, mapping at the same time the upper abdominal cavity. The working team should adopt uniformly Naruke's lymph node mapping or modification applied by the American Thoracic Society. The precision of the endoscopic image in Sigetu bronchial mapping and the bone gamma camera scan complete the pre-surgical appraisal added to the conventional procedures. With this methodology referred to above, learned in Japan, mediastinal surgical staging by means of the complete lymph node dissection and the use of the new international staging, we started working in February 1985, closing our series of cases in August 1989 to show results obtained. We perform the MLND that is done after the lung cancer resection. Steps of surgical technique are shown with synthetic operative drawing and operative pictures where we see the upper mediastinal triangle with an intact pleura that is open and carried on the lymph node dissection, finishing this dissection that includes N2, 1 to 4. The subcarinal, esophageal, and the ones of the triangular ligament, 7, 8, 9. We appreciate finally the complete dissection, leading elements completely free. The same is shown in operative pictures, the upper triangle and dissection in its different steps. On the left side, the technique is similar. We show a drawing with the entire open pleura and the anatomic leading element to be considered. The Thorax Hospital, Dr. A.A. Cetrangolo, where I took my first steps as thoracic surgeon, has operated 688 lung cancers from 1960 to 1985. This series was named Historical Cases by its current chief, Horacio de la Torre, to mark the difference with the cases when surgery is performed since 1985 through pleural mediastinal dissection in all patients. These cases include bronchogenic carcinomas, squamous cell carcinoma, adenocarcinomas, large cell carcinomas, and adenosquamous carcinoma. Age and sex distribution. From February 1985 to August 1989, I personally practiced surgery on 38 patients. Average age was 58.7. 30 males patients, 8 females. Histology and sex. 17 epidermoids correspond to males. This histological type was not found in females. 17 adenocarcinomas, 10 corresponded to males, and the remaining 7 cases to females. 2 large cell carcinomas, 1 adenosquamous carcinoma, and 1 others. Lung cancer topography. Right lung, 23 cases, left lung, 15 cases. Right upper lobe, 13 cases, and 4 cases with extension to segments of other lobes. Right lower lobe, 6 cases. In the left upper lobe, 9 cases, left lower lobe, 6 cases. Topographic, tumor, and node involvement. Out of the 13 cases in the right upper lobe, 7 were N0, 2 were N1, and 4 N2. Of the 4 cases of tumor with upper and other lobe involvement, 2 were N0, 1 was N1, and 1 was N2. Out of the 6 cases of right lower lobe, 2 were N0, 2 were N1, and 1 were N2. Out of the 9 cases of tumor in left upper lobe, 7 were N0, 1 was N1, and 1 was N2. Out of the 6 tumors of the left lower lobe, 4 were N0, 1 was N1, and 1 was N2. We had more tumors in the right lung that furthermore showed a marked difference in number concerning lymph node invasion. 11 N0, 47%, 12 N1 plus N2, 53%, in the left lung, 11 N0, 73.3%, and 4 N1 plus N2, 26.7%. Tumor and pathological staging. We have a higher percentage of patients, 68.4%, that were submitted to surgery in stages with T2 and T3. Tumor and lymph node variable in anatomopathological appraisal. In the tumor and lymph node variable, we find that out of the 6 corresponding to T1, 4 were N0, 1 was N1, and 1 was N2. Out of the 11 T2, 5 were N0, 3 were N1, and 3 N2. Out of the 15 T3, 8 N0, 3 were N1, and 4 N2. Out of the 6 T4, there were 5 N0 and 1 N2. This relationship leads us to believe, with scarce statistical value due to the low number of cases involved, that the T3 and T4, while involving chest wall being painful or mediastinum, vascular or bronchial syndrome, were diagnosed. Although this may seem a paradox prior to lymph node invasion. Tumor and histology. We have seen under age and sex distribution 17 adenocarcinomas and 17 epidermoids, which show the current balance between those histological typing, but at the same time that there are no differences between them in the various T. On the other hand, concerning staging, there seem to be more adenocarcinomas in E1 and more epidermoids in E3. Clinical, surgical, and anatomopathological comparative staging of N2. Valoration concurs with the clinical, surgical, and anatomopathological staging in 25 patients, and discordance is shown 13 patients. This shows that N was overvalued in 5 patients and was undervalued in 8 patients, 21%. This undervalued 8 patients represent the 21% in which, through the pleural opening practice, we found metastasis. In other times, we would have left the cancer, and this coincides with the international figures that refer to a 20-25% of lymph node with metastasis, that macroscopically do not appear to be such during surgery. Surgical treatment resectability: out of the 38 patients submitted to surgery, 2 were not resected, that is, resection index would be 94.7%. In all surgeries, MLND was performed: 5 segmentectomies, 13.2%, 18 lobectomies, 1 with sleeve resection, 3 bilobectomies, and 10 pneumonectomies. Pneumonectomies, lobectomies relationship is similar to other series. Type of resection and N. The 5 segmentectomies had N0. Out of the 18 lobectomies, 12 were N0, 2 were N1, and 4 were N2. Bilobectomies were 1 N0, 1 N1, 1 N2. In pneumonectomies, there were 3 with N0, 4 with N1, and 3 with N2. Extensions corresponding to T3 or T4 were performed: 5 pancoas, 1 with vertebra and 1 with subclavian resection and anastomosis. Other 4 were extended to vascular structures: 1 to cava, N0 epidermoid, 1 to azygos vein, N0 epidermoid, and 2 to the atrium, N0 and N1, both adenocarcinoma. The remaining were current extensions to pleura and chest wall. We encountered no complications in the post-surgery period attributable to MLND. Although surgery is to last around 20 minutes more, the fact of opening the mediastinum at the beginning allows for an easier and safer handling, resulting in a similar period of time as in a single resection. Post-surgical complications due to surgery: 2 fistulas, 1 on the 5th day and the other on the 11th day, following a pleural empyema in 7th day. The actuarial curve is not significant due to the low number of patients. We believe our figures have substantially improved. 17 patients died and 15 are alive without recurrence as at August 30, 1989. We still understand by radical surgery the pulmonary resection, lobectomy or pneumonectomy with MLND, in the belief that it is the only surgery presumably curative. Segmentectomy plus MLND and complementary pre- and or post-surgical treatment, although it does not follow the basic principles of the definition of radical surgery, in very selected cases we considered it as such. The experience in MLND gave us the key to a most aggressive oncological surgery. We understand today that we would have resected tumors that we took for non-resectable before 1985. This is due to an improved technical handling and to a philosophical medical position with resective attitude. We do not doubt of the benefits of mediastinoscopy in staging. We do not share the idea of carrying out this procedure, since it will not change our therapeutical criteria vis-a-vis the presence of ipsilateral lymph node involvement N2. Prior to 1985, we did not open the mediastinal pleura during surgery except when outstanding lymph nodes during surgery led us to presume invasion. We have followed a mistaken criteria, since all cases statistics show between 20–25% of mediastinal lymph node invasion in places apparently free of metastasis. Since 1985, we adopted ML&D as routine. In only a very few cases, we perform biopsies of isolated lymph node groups due to very particular conditions in patients with high surgical risk and complicated anesthetic conditions. During surgery in our 38 patients, we had one lymph leakage on the right of the thorax apex solved with simple suture that did not modify the post-surgical cause. In other patient with pleural peel, we damaged the esophageal muscle. This was correct with suture, normal post-surgical cause. Concerning the new staging, we believe its advantages can be summed up in the following facts. Net difference between E1 and E2 based on factor N that is reflected in an evident prognosis difference for both groups. Division of the old N2 into N2 and N3 that would also indicate a net difference between the reasonably resectable and those which are generally non-resectable. The division of the old T3 into T3 and T4 marks as well a net limit between the reasonably resectable T3 and those which are generally non-resectable T4. We are not able to show conclusions with such a reduced group of patients and for a short follow-up period, but our feeling is that the figures obtained are becoming similar to those of important foreign series. We expect and hope that following this path, we will attain survival figures over 30–35%. What we indeed can say today is that we do resect patients that in other times would not have been resected, and that their performance status is excellent as compared to non-resected ones, even though they do not reach a 5-year survival. Should we perform pre-surgical adjuvant chemotherapy coupled to surgical therapy, we might also be able to resect certain patients that used to be considered unresectable. As a personal contribution, I would like to comment that we start an experimental and clinical activity intending to map the mediastinal lymph node by scintigraphy in the pre-surgical proceeding, injecting the radionuclide through endoscopy in the bronchial mucosa, but results obtained that not allow us to reach realistic conclusion as yet. Finally, according to results already mentioned, 61% of the patients, 22, resected were free from lymph node metastasis. The question would be, is it worthwhile to dissect mediastinal lymph node in this 61% without metastasis? For those who believe that this procedure is solely used for staging purpose, probably the answer would be no. Guided by important foreign statistics that support this therapeutical procedure, we believe it has a beneficial role. Furthermore, since it does not complicate neither the intra nor the post-surgical course, we follow this position in the belief that although in a few cases it leads to a higher survival rate. Arigato domo.